Good morning, and welcome to a special installment in the Formfast Educational Webinar Series. I'm Aaron Vaught, Director of Marketing at Formfast. Thanks for taking the time to join us today. We're excited to be featuring a distinguished panel of healthcare thought leaders today who will be discussing how the election results will affect the industry. We'll be sharing some insights and opinions on ways your hospital can prepare for the next 4 years. But before we begin, I want to review just a few housekeeping items. Webinar is being recorded, and you're welcome to view that at any time after this session, and as well as any of our previous webinars at formfast.com/webcasts. Will be broadcast through your computer speakers. If you're having troubles hearing the audio, please contact me via the chat window on the right side of your screen. Questions at any time in the Q&A section or that window on the right side of the interface. Questions will be reserved to the end of the session that don't disrupt the flow of the discussion. We have a few new faces here at the Educational Webinar Series. I just want to take a quick second and introduce Formfast and let you know a little bit about who we are. We provide information solutions for healthcare, which include electronic forms management, or eForms. It's also known as forms automation. Solutions is another type of solution we provide. Business intelligence tools, electronic document storage, and output management. What we can do for your hospital is summed up in one word: simplify. So if you're a business leader, a hospital leader in your organization, we can help you simplify your process by giving you insight into those tasks that are being performed, and giving you insight into how you can improve safety as well as revenue loss. For department leaders, we give you tools to help you better manage your department, tool dashboards, to help prioritize tasks. And for those who are struggling with a particular challenging task, we can help you simplify that through automation, through automation solutions. So to meet our panel for today. The administrator of Shriners Hospital for Children in St. Louis, an organization which is recognized as a leader in treating orthopedic conditions, featuring some of the world's most renowned surgeons. A distinguished career in healthcare with over 20 years experience at the BJ Healthcare System before taking his current position at Shriners in St. Louis. He is also a fellow in the American College of Healthcare Executives. Who is a noted author, thought leader, and solution architect in the healthcare industry. He is formerly the Director of Information Services and Director of Business Intelligence at Doc Hospital at Renaissance, one of the most respected providers in the country, and noted as one of the most profitable as well. His tenure there, the hospital grew from 83 to 508 beds and implemented a number of health IT solutions, including workflow automation, to help tasks. Scott is now serving as our Director of Solution Architecture. Also noted he's an author, and he's working on his 14th book entitled Creating the High Performance Hospital. Tom is the Senior Director of Federal Affairs for the Healthcare Information and Management Systems Society, also known as HIMSS. He directs all of HIMSS public policy activities with federal agencies, including analysis and response to federal regulatory requirements, and leveraging HIM member subject matter expertise and health IT public policy development. And the Federal Affairs team provides staff support to HIMSS community groups, including the HIMSS Government Relations Roundtable, the Federal Health Committee, and the Public Policy Committee. He is a HIMSS Fellow and a graduate of the Senior Executive Leadership Certificate Program at Georgetown University. Ken is Chief of Healthcare Technology Online, online publication and resource center that delivers healthcare technology systems, implementation trends, best practices, and product information. Ken has been a technology journalist for nearly a decade, serving as an editor-in-chief for Integrated Solutions magazine and editor for Business Solutions magazine at that time frame. Dr. Jeff Bauer. Dr. Bauer is an internationally recognized healthcare futurist and medical economist. As an independent industry thought leader, he forecasts the evolution of healthcare and develops practical approaches to improving the medical sector of the American economy. He is known for his specific proposals to create an efficient and effective healthcare delivery system through stakeholder partnerships and other initiatives focused in the private sector. He's published more than 225 articles, books, web pages, and shows on healthcare delivery. His latest books are Paradox and Imperatives in Healthcare: How Efficiency, Effectiveness, and E-Transformation Can Conquer and Optimize Quality. Another recent book is Statistical Analysis for Healthcare Decision Makers. Welcome to all of our panelists. Thank you for joining us. Today is going to be moderated by Allison Harding. Allison is our Director of Special Projects here at Formfast. She's a graduate of Princeton University and University Law School and brings a wide variety of skills to Formfast. So this time, Allison, I'm going to turn it over to you.
Great, Aaron, and thank you to our panelists for joining us, as well as thank you to our participants for joining us this morning. So let's dive in. Firstly, I'd like to note to our panel that although some of these questions are going to be posed to one person initially, after that person has had a moment to comment, I'd encourage all of you to also share your comments. Let's jump in. I'd like to start just briefly by talking a little bit about the current legislative landscape in order to set the stage for our discussion. So as you know, President Obama will be in office for another 4 years, which means that the Patient Protection and Affordable Care Act, common Obamacare, will be implemented. To you, if you would please just provide us a brief synopsis of the present purpose of the Affordable Care Act to set the stage for our discussion today.
Sure. The dating back to prior to the Obama administration, there's been a lot of discussion around healthcare transformation, and there has been a considerable amount of worth of what healthcare transformation really means to the various parties. But of course, the Affordable Care Act in 2010 was intended to provide a national format for that minimizes the existing insurance care-based program to allow for more Americans to receive care, thereby address of the growing insured population through health information exchanges, or now being known as health care marketplaces, and then also addressing the rising cost of care delivery in the U.S. through the optimization of health IT, leveraging the health IT provisions of the Recovery Act from 2009, as well as the quality information, or the quality improvement information can be provided to facilities to then drive down the cost of care, therefore drive down the cost of care. At the same time, we're learning about how to provide better care across the country. I think many will argue as to whether or not that's this is the correct approach, but all would agree that we need to address the rising costs of care in the U.S.
So much. So with that, I think that you've already touched upon the fact that there's a lot of uncertainty and fear and misinformation that are pervasive drivers in healthcare right now. So now that the election has been decided and there is a greiter degree of certainty regarding the future of the Affordable Care Act, the each of you on the panel view to be the most important step that healthcare providers should be taking right now in order to begin moving forward towards meeting these new expectations?
Picture is there. I'll go first. Of this Larry again. I think where eligible providers and hospitals, if they meet the eligibility criteria, should be working towards becoming meaningful users for two reasons. One, because of the intended improvements in care for their patients, and secondly, if they're Medicare, they seek reimbursement from Medicare. Starting in 2015, you've demonstrated being a meaningful user by 2013 in order to not receive a payment adjustment from the Medicare program. That is in the law, that it's a 1% decrease in reimbursement for particular, and it has the ability to grow over 2016 and 17. So that's the first item, is working towards becoming a meaningful user. Secondly, understanding what your healthcare system and your community is going to be planning for the Affordable Care requirements. In particular, the accountable care organizations in your local community around it, as well as the secondly, with insurance exchanges or marketplace that are being developed by the states. Under how you fit into that ecosystem will be incredibly important. And then thirdly, hold the officials, both federal and state, accountable for hold their feet to the fire, if you will, on the consistency of the reporting requirements across the programs. The Affordable Care Act requires the Department of Health and Human Services to work with the states to decrease the administrative burden for providers and hospitals around ability of patients, around electronic funds transfer, to making it easier for systems to be health system providers to be reimbursed, and then thirdly, for back to a national quality strategy and plan, making sure that providers and hospitals do not have to report the same information to 6 different organizations. Therefore, hold their feet to the fire to make sure that those components, particularly reporting requirements, are streamlined. I'll turn to others then.
This is John Gloss, and I'd like to just have some comments from what Tom led into. Date myself here, but you know, healthcare traders, we've been focused on quality and cost. I'll date myself to 1983 when the DRGs were first implemented. And many people are saying the Obamacare Act is really the probably overhaul of the healthcare system since the implementation of Medicare. Focused on cost and quality all these decades. What's different with this one is the transparency, and kind of Tom touched on it when he began to talk about reporting. And there's transparency around so many different metrics, not only around cost, but also around quality. So if it's not meaningful use, it'll be value-based purchasing. It'll be the readmission rates. It'll be hospital-acquired conditions. All those things are now transparent. And we're actually seeing it in several different publications where it's released to the media in terms of how do you stack up against your competition within your local community as it relates to perhaps hospital-acquired conditions, readmission rates. Shortly we'll be seeing things about meaningful use and value-based purchasing. From a healthcare provider, my focus changing substantially in terms of my focus on quality and cost, but I'll be much more sensitive to it in terms of how will I look in the eyes of the public now that my information becomes transparent.
John, this is Ken Congdon with Healthcare Technology Online. Just to reiterate on that, I think you really touched on a good point with transparency. I think a ton of healthcare providers have always been focused on quality, but really being able to demonstrate that quality and making that data prevalent and being able to benchmark yourself effectively within your own organization and with other organizations is becoming an increasing demand for healthcare providers. So I definitely think that that's going to be something that providers should be looking to do, having those measurable metrics and being able to benchmark themselves against other providers and constantly be able to move toward improvement and maximize their reimbursement. The other thing I think that needs to be in terms of what Tom said earlier about becoming meaningful users. One of the things that a lot of healthcare providers should look to start to do is really start focusing on the patient engagement element. I think we're seeing that become prevalent with the criteria that was issued in and around Stage 2 meaningful use, and some of the metrics that are out there around patient engagement. While it could be difficult to force patients to engage, the benefits of it are noted. There was a by the VA coordinated care and home telehealth program showed that patient engagement led to 18.74% reduction in hospital admissions, a 25.31% reduction in bed day care, 8% patient satisfaction, a $1,600 average cost per patient a year compared with over $13,000 cost per patient a year for primary care and $77,000 cost per patient a year for nursing home care. So really the benefits of patient engagement are out there, and there are some tools and processes in place for the person to start taking advantage of now to get themselves proficient in that area.
And so I'll go ahead and move forward then from there. But all three of you sort of touched on the fact that hospitals will need to start delivering health care amid lower reimbursement rates. And I want to delve back into that a little bit further. That sort of got skipped first. So John, first, if you would first discuss what you think the contributing factors are in the slowing of revenue growth for hospitals. And each of you would go ahead and share what you feel like will be involved in implementing meaningful cost reduction strategies going forward.
Boy, I could go on many different tangents, but let me first start with health providers. Historically, we've not done population management well. We'll take care of very well our episode of care. If it comes in with a heart attack, we'll manage that well. But what we don't do once they get discharged, so what happens in terms of does the patient follow their drug regimen, if they have some wound dressings or something, if it's a surgical operation, how's their post-op care. What the Accountable Care Act really forces us to, if we get into value-based pricing, we're reimbursed for the full continuum of care, not just the episode of care. That's going to make us do things differently. So we're going to be very interested in partnering with, what is the patient's, are they taking their medications? What's their compliance with that? What is their post-op care? What are some follow-up calls that we make to the patient? Is there some rehab care? Is there an affiliation with maybe a nursing home, a home health agency? So I begin to structure ourselves differently. We won't just be focused on the acute hospitalization. We're going to look beyond that in terms of 3 days out. This whole reporting period about readmission rate within 30 days for heart attacks, pneumonia, and stroke, that has certainly raised some concerns among the healthcare providers in terms of if I'm one of those, whatever it is, 297 hospitals that got reported as losing the full amount of 1% Medicare reimbursement next year because we had a worse than average readmission rate, that's a wake call. And believe me, those 178 hospitals, whatever the number is, they'll begin to take a look at those metrics and hardwire some things in terms of what can we do differently to improve those outcomes.
Sure. Would anybody else care to comment on cost reduction strategies moving forward?
Yeah, Jeff here. I'll chime in. I'm the futurist. I'm the guy on the panel that looks into a crystal ball, and I'm the contrarian. I wouldn't disagree with any of the prescriptions that have been laid out. All the discussions of transparency and demonstrating quality and patient engagement and learning to do more with less. Those are same I promote in my presentations and what I write. But I don't believe that the Affordable Care Act is very likely to be implemented as legislated. And I think the economy is absolutely going to get in its way, and I don't think that the politics of the next couple of years are going to be as generous to the administration as the election results have sort of led some people to assume. It doesn't change the outlook. As I say, I just very strongly encourage people to think of doing all these things without counting on the Affordable Care Act as the resource that's going to make it possible, or the regulation hammer that's going to make it necessary. I really think the task goes back to the premise behind the Affordable Care Act, which is that the healthcare system we've had in the United States, what we've built over the last 50 years, is unsustainable, and we have to reinvent it. So the economist in me is very much focused on what economists is known as creative destruction, pretty much rearranging the resources and doing exactly the things John just talked about, looking at patients differently, from the acute care concept of admitting patients to hospitals to take out whatever it was that was ailing them, to managing it so that they don't have to come in the next time in the first place. I mean, those are dramatic transformations made possible by the new change in medical science. But at the bottom line, I recommend to anyone I talk to that they're going to have to approach the future with no increase in revenue. To me, it's not an issue of slowing revenue. I don't think that the cost model, the agreement that the hospitals made to presumably get more revenue from patient insurance is going to play out. But excited, as people from Formfast know, having worked with me in the past, of getting off the paper trail and very transparently figuring out how to do a much better level of quality with health care for a fixed amount of money. And there's evidence around the country it can be done, but I, in conclusion, think we better not count on the Affordable Care Act or high tech to provide the resources or to make it necessary.
And this is John Gloss. And independent of the Accountable Care Act, regardless of the Republicans or Democrats, in terms of control of the House, the Senate, and the presidency, to make change in terms of the cost of health care. And if you look at the budget this year, the federal budget, number one is defense, number two is health care, number three is the pension plan. The bill, which is a congressional budget office, they're predicting that in 2 years, health care will be the number one ticket and cost center within our annual budget, and $1 trillion. Our annual budget is, in essence, a little less than $4 trillion, but for health care to consume almost a fourth of that, continue at that rate, and something has to change. So, irregardless of Accountable Care Act, if it's not that, we healthcare providers have to change and learn how to make money on Medicare to be very efficient, and we're going to have to find ways to reduce our costs. There's some collaboration that occurred within the Midwest, and it was announced in Modern Healthcare. It was Cox Medical, Springfield Memorial, BJ, and St. Luke's in Kansas City. And it's really it's a collaboration. It's not a joint venture. But their whole intent is, how do they go forward in a collaborative approach? It's not affiliation. It's not an acquisition. But how do they go forward and do population-based management and have some economies of scale? So it's not just about access to credit or access to capital, how to put resources for debt. I think what's happening is we're finding some very creative ways and different ways. Recently there's a fair of acquisitions in the healthcare plans in terms of insurance industry. We've not customarily had insurance products. We went through a period of time, about a decade or so, where many of us got involved in insurance plans but kind of divorced ourselves because we didn't know how to run that business, which is a whole new renewed interest in terms of population-based management and people understanding actuarial-based health care and get back into the insurance business. We saw Partners Healthcare in Boston recently acquire a insurance product. DP Medical, they recently purchased Medicaid. So I think we'll see more insurance activities by healthcare providers getting either in a partnership or relationship with them to better understand outcome management and the insurance side and the actuarial side of the business.
Hey, John Bauer here, just real quickly, totally concurring with your assessment there. And well, I think the key, and you gave some great examples of it, multi-stakeholder partnerships. We can't solve the problem just hospitals getting together with hospitals. It's a case where it's going to require some totally new relationships between payers, purchasers, providers, patients, and great examples. What is all of those are examples moving very fast, very impressively without the Affordable Care Act, and that's really where I think we need to look for our inspiration.
This is Ken with Healthcare Technology Online. I mean, definitely you guys are making some great points. And not to bring it back to the question, but you're focusing on cutting costs. I think part of the questions were, what deal might be involved in implementing some meaningful cost reduction strategies, and the kind of elementary things that I'm coming across in the provider I'm talking to is kind of a going back to basics and applying those strategies and methodologies to the process of healthcare. There's so much waste in all kinds of elements of a healthcare provider's day-to-day activities that I think providers are realizing that they can do it more efficiently, and the outcomes can be almost immediate upon putting those processes into place. I recently wrote an article about Good Samaritan Hospital in Nebraska, and they were able, just by apologies from Kaizen, through their documentation processes, significantly reduce the length of stay of figures within that hospital. And it wasn't, it was small things like improving their documentation flow and checking and consolidating their storage facilities so nurses weren't walking around so much, and doing dual assessments as opposed to a nurse doing an assessment and a doctor coming in another assessment. It's simple things like that we're making an impact on the cost reduction efforts of that particular facility, and I'm seeing that more and more being applied to other healthcare providers' activities.
Yeah, to your point, Ken, this is Scott Fuller. To your point, I think it boils down to hospitals are getting in that situation where they're to more with less in terms of resources, financial resources, but also personnel resources. We all know that we have a pretty significant physician shortage in the country, and it doesn't look like it's going to get better anytime soon. But also just, in terms of personnel issue, people that understand more sophisticated IT systems, as more clinical people move into an EM-based hospital where you have CPOE. There's a little bit of gap there for a lot of employees, and because hospitals can't necessarily afford to hire as many people as they wish they could, they learn to stretch the resources that they have currently. And I think that is going to be definitely most hospitals in the future, and how they're going to navigate through these changes, because there isn't going to be a large influx of resources that's going to help them get this. You're going to have to kind of look inward, and you're going to have to look to become more efficient. And then whether that means cutting costs, finding more revenue with the square footage you have, media, the chance of being more transparent, having your competition and your customers being able to just click away and see how your outcomes are compared to your neighboring hospitals. And I think kind of at the nucleus of the challenge.
Scott, this is John Gloss, and you're right. IT can be a great enabler as we move forward in reducing costs, and it's finding out those opportunities where it can assist employees to do things better. We work in my industry. It's incredible in terms of the procedures and the activities activities that we do. And then taking a step back and asking ourselves, how can we do this much more efficiently? How can IT enable our work to make it much more productive?
Absolutely. Any additional comments sort of regarding these cost reduction strategies? And I'd actually really like to go back to something that Jeff had touched on about the assumption that all of these health legislative will be moving forward. So Jeff, if you could, I think it's generally accepted that there is strong bipartisan support for health IT, and then you mentioned high tech and meaningful use as part of the somewhat divisive American Recovery and Reinvestment Act. The impact of many health IT initiatives is being spurred in large part by money from federal stimulus programs, which we've obviously touched a lot on. So that government spending is currently a huge national concern. I would like you to delve into a little bit what you think the future is for programs like Meaningful Use. Do you think they will go forward as envisioned when enacted by a Democratic president and Democratic majorities in both chambers, or a different future?
Well, I spend a lot of time thinking through the answers to that question, and I must tell you that the image in my crystal ball is a little bit fuzzy. But in other words, things could go either ways. But on balance, I think they're going to go against the implementation as envisioned, which appropriated as much as, depending on the way you looked at it, $27 to $31 billion that would ultimately be doled out to meaningful users. Given a lot of the delays that are now built into the program, and the fact that there are some key leaders that are concerned that they voted for not the High Tech Act, not just in itself, but for the whole American Recovery and Investment Act, in which high tech is embedded. They did that on the premise that this was money to bring new users into information technology. Nobody supports that more than me. I'm as strong a person as there is, and getting off the paper trail. Information technology is critical, but I'm not convinced that the high-tech program was the best way to go at it, because it was designed to bring in new users, and it's very clear in the legislative intent, and yet most of the money is going to people that were already in IT. And I think that's going to be more of a problem than people right now recognize. But separate and apart, the funding isn't going to be there. As John and I think Ken too mentioned, the federal budget is just get out of control, and the revenues aren't there. Often we could count on foreign markets and our export sector to bring us back, but the world is in a mess. We can't count on Europe to buy our products. China seems to be looking at an end to its growth. So the economist in me, remembering the old message of Willie Sutton, the bank robbery, money is, I can't find where the money is. So I think we're going to see some really serious crunches. That would lead to great pessimism, were it not for the fact that, as several of the speakers have mentioned, we have a lot of waste in healthcare, and we have a lot of proven ways to recapture that waste and reallocate it to better things. So again, it comes back to my point. I could determine whether high tech will be fully implemented or whether the Affordable Care Act will be implemented. The point is, we won't see any more money. I feel very comfortable about that, even though I might be a little bit hesitant on the future of the laws. The money isn't there, and so we've got to go about doing the things that John and Scott and others talked about.
It's almost embarrassing for me to admit, but I'm going after meaningful use incentives. And my population is primarily pediatric, so it's Medicaid, not Medicare. My incentive is because there's for me to achieve, to demonstrate that I've got a certified and registered electronic medical record. And this came back from the Missouri Hospital Association. That was last week. And I was surprised as I talked with some of my colleagues and fellow administrators on how many have not had COE in terms of physician order entry, and how many of them are implementing it, not in the concept of it'll be meaningful use for the whole use of MU. They're really going after because, hey, there's incentive dollars at stake. I go ahead and indeed get registered and certified, I can then indeed have access to these incentive dollars. That changes once you collect on your incentive dollars after a year or two. Then hopefully you'll begin to demonstrate through your reporting periods that indeed you're using it meaningfully. But the real push for me was there's some incentive money at stake here.
Right.
And John,
to that point, John, this is Tom Leary. To that point, what we've heard, within HIMSS, a lot of our members talk about the incentive, but also having to go before their board to describe why not only did they not collect the incentive, but they're also being dinged 1% in 2015, and then 1.5% in 16, and 2% in 2017. That's an incentive in and of itself. But getting to the point of then you have provide order entry and you have in place that then the next round is what can I do with this clinical and business intelligence feeds into the improvements in care coordination that the Affordable Care Act is trying to drive to address a lot of the waste in healthcare. So it's really is in and of the incentive in and of itself is an entitlement. If you meet this certain criteria, the government is required to give you the incentive payment. So that's information. That's clear that it's that is there. It's then the cost savings, that cost avoidance that's anticipated in the Affordable Care Act from the clinical business intelligence that drives up quality and therefore drive down cost is what I think, to Jeff's point, is still debatable.
And to say it, because believe me, this is not the way it would be in my ideal world, Bauer here.
Yeah.
But Tom is absolutely right. That money is authorized. The law is unambiguous. But you have to remember that each year Congress has to appropriate to meet authorizations, and I fear the continuing economic downturn is sadly going to lead us potentially to some surprises.
I'm kind of on your side here. I write about health IT for a living and meaningful use, and your funds are authorized. But with the fiscal cliff bearing down upon us and cuts potentially made to programs across the board, I don't think anything is necessarily safe, and those funds could be a potential cut to try and make up for what we're putting toward deficit right now. There was a recent article that came out that said Fromm that he would have eliminated the incentives that are geared toward meaningful use as one of his cost-cutting measures. So I don't think that those funds going into these tough economic times are necessarily safe. I think that you could see some cuts there.
I think what we remember is that the American Reinvestment Act had embedded in it the appropriations for the remainder of that fiscal year and gave no end date money for certain programs to the incentive program. So that's where it's authorized, and it's also had the appropriations component in it. So that's the to be careful on as we talk through the ease with which the money could be moved to other programs or just zeroed out.
I guess on that note, if we are to assume for the time being that meaningful use is here to stay and will continue to be funded, I would take a few steps back then and have us maybe into that a little bit more deeply. If any time you'd like to give us a broad overview of what you see as the differences between the stages in meaningful use and sort of a sense of what timeline we might be looking at regarding the different stages, especially focusing a lot of energy towards Obamacare and what the interaction might be.
Stage 1 is extended now through 2014, so Stage 2 will go into effect for hospitals beginning of the new fiscal year, in fiscal year 2014, which is actually October 2013, and 2014, January 1 for eligible professionals. The key components in terms of changes from Meaningful Stage 1 to Meaningful Use Stage 2 is, of course, that timeline delay, but then the increased focus on what would have been core and menu measures. Many, if not menu measures, have been moved into core, so it's clear what they're trying to do is raise the bar for to drive the quality improvements and to make the incentive payment requirements, make it to achieve meaningful use in the second stage. The improvements in whether it's smoking cessation or CPO, computers for order entry numbers. Once I've shown as a facility that I can achieve the 30% in stage 1, I should then continue to move it across my organization. Therefore, stage 2 has an increased percentage, for example. The other key component as part of meaningful use and adherence and certification criteria is that they've made their bright line between the certified products for stage 1 and the certified products for stage 2. Could you that the products that were developed to meaningful use stage 1, all 100 products that have been certified don't necessarily meet the requirements for stage 2. That's why they're through the Office of the National Coordinator has established the 2014 record addition for that all products need to, if they intend to be part of meaningful use stage 2, will need to go through. So if you are preparing for meaningful use and you are going to be doing it at the end of this year, or most likely you'll be at this point in the year, you'll be focusing on 2013. You have the option of utilizing a 2011 edition or 2014 edition of the books. But once you're focused on meaningful use stage 2, it has to be a certified 2014 edition of the product.
Sure. So along those lines, maybe to expand out a little bit, if each of you might want to comment on if you're sort of looking at this meaningful use incentive reimbursement program, do you believe that it's going to create the intended results of improved quality, improved safety, improved efficiency, and better outcomes? Are there better ways to go about that? What are your thoughts?
With healthcare technology online, I recently wrote an article. It was actually a couple months ago about kind of this conundrum, and I want to start by saying I'm an advocate of the Meaningful Use program. Obviously, I think it's done in the industry the necessary push it's needed to become adopters of health information technology, specifically electronic health record technology industry. But one of the things I think that has become prevalent in my coverage of this space is that I found that the people successful with EHR implementations are those that have done so without the incentive dollars kind of dangled in front of them. They're making the strides to address a business outcome or objective or problem that they had, and they put the EHR technology in place to address those needs and improve those outcomes. I think what you're starting to see, and I think an unintended result of the Meaningful Use program has been that people adopt often implement the technology just in an effort to get the incentive dollars, and doing it or applying the technology in all cases in an effort that's in a way that's producing the outcomes that we would like to see from that technology investment and installation. I think providers need to be wary of that, and they need to be obviously go try and capture the meaningful use incentive dollars that you can. Those monies are out there to incentivize you and motivate you to do so. But when you're implementing the solution, be sure to still do it under the guise of, well, how is this going to address some business problem and improve and impact my institution in a positive way, help improve patient care, help improve productivity, reduce length of stay, things of that nature.
Yeah, Jeff, real quickly, supporting Ken's point, the issue is reinventing the way we do healthcare, and that ought to be number one. If you can make a few incentive dollars along the way, that's great, but the pursuit of the incentives must not get in the way of meeting each individual organization's needs to literally come up with a new business model and new partnerships and the like. And a lot of those things simply aren't envisioned in the High-Tech Act. So I think it has to be said that there are more and more CFOs who are being asked if the ROI on the incentives is okay. I mean, it's very appealing to look at a potential of north of $10 million over a 4 or 5 year period here to come in. But CFOs starting to put on the brakes if they feel the cost of getting those millions in incentives is even more money. So as I say, I'm agreeing with the absolute imperative for the digital transformation of healthcare. We're not going forward without it. But meaningful use pays off as the way to do it is got to be just on a case-by-case basis.
You know, Ken, I love what you're saying in terms of just don't do this because of the meaningful use incentive. There's got to be a real leadership commitment to improving what you measure. And what I like about the Accountable Care Act, it really is forcing people to look at metrics. And somebody is going to come up with some disruptive game changers that's going to change our industry and the way we provide care. And they're going to be innovative. And if we continue to be focused on improving what we measure, we will have better clinical outcomes at a reduced cost.
I agree.
Okay. So along those lines, I think you've all noted that reinventing healthcare is sort of an underlying theme with everything we've talked about today. And actually, I'd like to turn our focus a little bit to the idea of hospitals as a business. Reinventing the ways that hospitals operate as a business. So for years, hospitals have been focusing on upgrading the clinical side of the business at the expense of, for sort of lack of a better term, the business side of the business. The industry is really focused on the success of the electronic medical record, for instance, while back office departments and systems would be described as outdated, that sort of thing. So I'd really like each of you, if you could, to comment on your enterprise-wide process redesign and how hospitals should be looking to change their back office technology as well to support reduction cost strategies and move forward into maybe a different business model.
Maybe I'll go. Allison, I'll go first. I don't know that is not focused on the revenue cycle, and oftentimes the revenue cycle is that back office operation. We certainly have opportunity as an industry to make improvements and learn a lot of lessons from some other industries, but it has to focus among our industry for revenue cycle.
Power here, again, agreeing. It's not just an issue of clinical records. The case for electronic health records is just open and shut, and I think it's been diverted too much lately by some concerns with security that can be dealt with and some issues of the learning curve, which we should have expected and didn't crank into our plan for implementing IT. We want to have our clinical records for a variety of reasons on electronic databases, but this logic goes to the back office, and autonomous I spend a lot of time comparing healthcare, as a rather retrograde industry with other industries that have really transformed themselves by digital transformation, like banking, like communications, like retail, like manufacturing. And a paper record is just rare. The case for paper still exists in small part, but again, what I call the digital transformation is necessary throughout the organization. And my fellow panelists here who are saying we need to look everywhere, not just clinical quality, but revenue management and contract enforcement and recruiting and managing medical groups and care in the home. Not going to my dreams without basically almost everything being electronic.
There, Jeff, it's because it's as it's pointed out, the Affordable Care Act also has the administrative simplification requirements around accommodating rules for eligibility, which the insurance industry has been funding since 2006 to decrease the time spent by staff of just the the multiple insurance plan the particular patient is eligible for. I think the more significant administrative simplification Affordable Care Act is the funds transfer and electronic remittance advice requirements save anywhere between $20 and $30 billion a year, and they're being smart. CMS is being smart, suggesting that the insurance industry and the banking industry nonprofits work along with the health IT nonprofits to educate providers on why this is a good thing for the business end of their healthcare delivery, and the costs up for them, as well as the up the time it takes for them to get reimbursed for the care they provide. Just a couple examples.
All right. Please go.
This is Scott Fuller. I think it's gone through implementing MAR. It's even sort of a crazy time for a hospital, mainly because you're changing the way your clinical works. You're changing the way doctors do their job, and there's definite changes in that. But at facility and other facilities I've had the pleasure of working with, I find it's actually a good time to look at all the processes in the hospital at the same time. Really, my former CIO, spoke from the loading dock to the bedside. We're towards meaningful use. We're spending a lot of time in the clinical arena, but much in benefits to be gained, not only in revenue cycle departments, but even support service departments. Different areas that are just very equated in the way they work. And why we, the job of focus on what we need to do to make, the patient care better. There's still that business side of the hospital that, suffers. And one of the things that Affordable Care Act is supposed to do is start having that discussion. We're looking at the clinical side, and I think in a lot of hospitals that forces them to look at some non-clinical type processes that are added and need to be fixed for either cost savings or to a shortage of resources. And this is it's forceful to inward at themselves and see what the deficiencies are at.
Any additional comments concerning the business sort of process redesign among hospitals?
Well, just quickly linking back to a comment I made that seemed to have some support from other panelists, and that's the need for multi-stakeholder partnerships to recognize that we're not going to solve the problems of healthcare without really enhancing and institutionalizing our relationships with the purchasers and the payers and the patients. And that transcends everything. That's finance, that's patient education, that's discharge planning. Just reinforces the very important central point of your question. Yeah, it's got to be across the enterprise, not just clinical.
So before I toss it back to Aaron to tackle a few questions, I'd like to invite each of our panelists to provide any closing comments or messages if they've got any.
Well, bashful. I'm going to take hats off to the state of Missouri. I think that the health policy community as a whole looks at Missouri as being sort of retrograde because Missouri is one of 2 or 3 states that sort of stood up to all of this legislation and, in both legislature and through the ballot box statewide has said we're going to do this our own way. And as I, for my writings and for my speeches, look around the country to see who are the good examples of people doing it right, my goals are exactly those that have come up. I've frequently used BJC or Cox as examples of people that have created things. And so it's ironic that in a state that is nationally seen as being totally non-participative, we can find some of the best examples. So I'll just simply, my conclusion is hats off to Missouri and other people that sort of, show me, do it my own way. Hats off to all those that are making very progressive things and realizing it's got to be much more important than federal laws.
Say for 2013, what we should be looking at is meaningful use further along, and we have getting closer to the requirements for health information exchange and patient as a consumer engagement. There will be more scrutiny and more focus on the successes or the for interoperability that leads to health information exchange. So look for that to be a topic in front and center for both the Congress and the administration, as well as the states in 2013.
Yeah, a closing comment, and I think it's a great, exciting time, and we have an opportunity to really create a healthcare system and to be part of it. That healthcare is here for generations to come. That I've enjoyed for the last couple decades. That it's here for my children and their grandchildren. We have one of the, if not the most robust healthcare system in the world. It's one of the most expensive, which we need to control. But in terms of innovation, creativity, healthcare outcomes, and that, well, some people would debate in terms of our healthcare outcomes compared to other nationalities. But that being said, I think it's an exciting time that we are building our future for our children and our grandchildren.
Scott or Ken, any closing thoughts?
I'd echo what John said. I think it is an exciting time, and there is a great opportunity. We should be looking at this as an opportunity to improve healthcare. We need to cut the costs, like John said, but also protect the innovation and quality of the healthcare that we produce in the United States.
So with that, I'll toss it back to Aaron. Do we have any questions for the panel, Aaron?
Yeah, terrific panel, great discussion today. Like Allison said, we're going to open it up to questions at this time. As we're waiting for those to come in, there were a few that were submitted throughout the presentation. One, John, to you, it's kind of a follow-up to your statement about IT being an enabler in the hospital. What IT solutions should we be looking at is the question.
And I think Allison touched on a little bit. It's not only on the clinical side, but it's also on the non-clinical. It's the infrastructure in terms of the support infrastructure. So, if you've not done CPOE, I'd encourage you to do it, especially because, and not just for the incentive, but I think it'll get you in a better place in the future. So on that. You can hardwire regarding performance improvement activities. Somebody had touched on earlier about some quality metrics in terms of Six Sigma. We had very little discussion today about Six Sigma and our lean management, but there's opportunities and some IT systems that help support doing things better. It's really assessing where are your needs as an organization. Look at your metrics. Where do you have opportunity for improvement? And then prioritize, and that's where you want to put your resources. Don't put your arms around the whole organization. Get focused, and then take action.
Great. Another question along those lines, and this is to any of our panelists. What's the best way to invest our dollars? I have an open question. Anyone want to take a stab at it?
I think the silence speaks volumes. I mean, I think it's not a doable task right now to try and make the prioritizations that are necessary with I think all the demands that healthcare providers face. I think I'm just going to harken back to something I said earlier. I think what we providers should focus on is what's going to make the most impact, in terms of an investment for the hospital. Where are some of the biggest problem areas, and where can they focus those to the dollars they do have to improve those problem areas and really make the biggest impact on their facility in the short term, and then build off that. And I think that's going to be different for hospital. I think some hospitals that are further along down the EHR and meaningful use path might have a bigger initiative than that to tackle at this point in time, and you should be doing it to the betterment of your organization, keeping in mind some of the care coordination initiatives that we all have to get to as an industry. I mean, I guess the best advice I could get.
Not just a matter of doing an ROI on the initiative. It's then taking the piece and what impact will that have on the organization. So it's the balance of what's the return on the investment, then also what's the quality and impact that you're going to get with your effort.
Okay, a little bit over time today, and that's all the questions that we had submitted. If you have further questions, submit those to me at avot@formfast.com. Once again, A, V as in Victor, AUGT @formfast.com. I'm going to pass those along to any of our panelists and get you the answer that you're looking for. Let's take a moment to thank our panelists for today: John Gloss, Scott Fuller, Tom Leary, Ken Coggan, Jeff Bauer, as well as Allison Harding for moderating. Great, so thank you for all of your time.
Thank you.
As the session closes today, you'll be presented with a screen that will allow you to register for our next webinar in the Educational Webinar Series. I think John mentioned that revenue management is a topic for many hospitals. And we're speaking to that with a webinar entitled "Automating the Business Office: Denial and Rejection for Different Hospitals." So make sure you sign up for that. That will be on December 13th at 11 a.m. Central Time. You get a chance to request more information on Formfast if you'd like. We feel like we have a lot of solutions that are perfect to address some of the things we discussed today, including getting better information on how to measure quality and how to improve processes. So feel free to reach out to us to request more information or schedule a free consultation. We'd love to speak with you directly about your needs. And we hope to see you at the December session.